Professor Jonathan Sharabi to talk to us today about the autonomic nervous system and Parkinson's disease. Jonathan graduated from the Sackler School of Medicine in 1996, and he did his residency in the Sheba Medical Center in Internal Medicine. And after that, went into fellowship and in the NIH in Bethesda, and has been studying the neuroautonomic aspects of neurodegeneration and Parkinson's disease for more than 20 years. He is a key researcher in the field, has been published multiple studies in collaboration with the NIH after spending several years there, and actually is focusing his research on the neuroautonomic or the autonomic nervous system in general and in Parkinson's disease in particular. Jonathan is the director of the hypertension unit and the autonomic service in Sheba, and a deputy chief of the internal medicine wing in Sheba Medical Center. And I think he is the perfect person to share with us the current understanding about the role of the autonomic nervous system in Parkinson's disease. Thank you, Jonathan, for agreeing to take this talk. You have to open your microphone.
Yeah, I said thank you for the introduction. For a minute, I wasn't sure you're talking about me, but okay. Do you see my screen?
Yeah, we see it well.
Okay, so the title is a bit different, and soon you're going to understand why. Sick but not dead catecholaminergic neurons in autonomic medicine, implication for biomarkers, mechanism, and treatment. Before I continue, I want to, the world of autonomic medicine is wide and fascinating. And next month, we are going to publish a snapshot. For those of you who would like to get familiar with this topic, I'd like to acknowledge the two brilliant co-authors, Abi Ashkenazi and Gad Vatin from Tel Aviv University and Ben Gurion University. So I advise you to get the April 2022 issue of Neuron to learn about this domain. But the focus within this domain is, of course, autonomic failure. And the research focuses on primary forms of chronic autonomic failure. And by primary, I mean chronic autonomic failure that has no known secondary causes. 3 forms of primary chronic autonomic failure have been recognized. I'm recovering from corona, so every now and then I'm going to cough. Let's hope it doesn't go over through Zoom. Pure autonomic failure, multiple system atrophy, and of course, Parkinson's disease with autonomic failure, especially PD with orthostatic hypotension. And let's not forget that about 30–40% of Parkinsonian patients have orthostatic hypotension. Most MSA patients have orthostatic hypotension, and all PAF patients, pure autonomic failure patients, have orthostatic hypotension. So these aging-relating neurodegenerative disorders are posing an increasing public health burden as the population is getting older. And the main challenge is that there is no known treatment that slows the progression of these diseases. Now, the 3 primary chronic autonomic failure syndromes are synucleinopathies. And it's important for our discussion. PAF and PD are Lewy body diseases, of course, with deposition of alpha-synuclein in Lewy bodies in the brainstem and sympathetic ganglia. And in MSA, alpha-synuclein deposition occurs in glial cells, in glial cytoplasmic inclusion body in the brain. And because of the autonomic failure and synucleinopathy, I refer to these syndromes as autonomic synucleinopathies, with your permission. I would like to start with a presentation of a patient that I've seen a week ago, and he really got into my mind because it's very, very intelligent and and he asks very difficult question. He's 46-year-old man. A few years ago, he was running marathon and he's a high-tech person and he had 3 kids. And he started to suffer from orthostatic hypotension, erectile dysfunction. His sense of smell was bad. He didn't complain of any motor symptoms. He went around, and one of the tests that he put himself through was autonomic autoantibodies panel, which was negative. And then he came to our facility for evaluation. He had clear autonomic failure, and we sent him to MIBG scan, which was negative, meaning no cardiac innervation of sympathetic nerves. For those of you who are not familiar with this ligand, it's a ligand, it's an isotope that uses norepinephrine transporter and gets into sympathetic nerves. So if low radioactivity means that there is missing norepinephrine transporter containing cells, and meaning sympathetic denervation. So the diagnosis was pure autonomic failure, but then he asked a few questions that are very relevant to our talk. What will happen? And he was specific. Am I going to have MSA eventually? Lewy body disease? I'm going to have dementia? Why is it happening? I'm healthy, I'm eating well, I don't have any such diseases in my family. And can we do something to stop it? So it brings me to what Nir has mentioned in his introduction about the autonomic nervous system in Parkinson's disease. And the symptoms are very relevant and debilitating for many of our patients. Orthostatic hypotension, supine hypertension, orthostatic intolerance. These 2 initials represent a very debilitating situation. Just standing up in a queue for a few minutes is very difficult. They drool, cyanoria, gastroparesis, constipation, urinary symptoms, sexual dysfunction, hyperhidrosis, they sweat in unusual situations, hypo or no sense of smell at all, and REM behavior disorder. Their spouse can complain that they move all night, they kick, they live their dreams, not something that is very easy to live next to. Now, the test in order to make sure that this is indeed autonomic failure or primary autonomic failure, we do an autonomic lab. We look at blood pressure and heart rate response to a very simple maneuver, Valsalva, just increase the pressure of the abdomen, heart rate variability, bowel reflex sensitivity. We can use sympathetic skin response, smell test. As I said, what is available around the world is 123 MIBG scan, and of course, head-up tilt test and ambulatory blood pressure monitor. I'll start with the latter, and this is an example of what the blood pressure of this patient looks like over 24 hours. At night, do you see my cursor? Okay.
Yes.
At night, the blood pressure is high. Daytime, it's very low and can sometimes be extremely, and they faint. If we do the Valsalva maneuver, and just by looking at blood pressure continuously, well, they increase the pressure of the abdomen. So we can see that normal, healthy subjects, the blood pressure goes down immediately because we increase the pressure in the chest, but then the bowel reflex and sympathetic activation responds to that, and heart rate goes up, and the blood pressure reduction, it stops, and there is an overshoot. So this is a normal response, a very simple maneuver, but it's like turning on the light. If the light turns on, all the wires is intact. When the light doesn't turn on, then we have to look where the problem is. all the way from the knob to the lamp. So this is what happens in people with autonomic failure. If we will tell them to increase the pressure in the chest, blood pressure will go down all the time until they will faint, unless we will tell them to stop. And then it gradually goes up, and heart rate doesn't even sense, doesn't respond to that simple maneuver. And if we do PET scanning, this is not the scanning that we do, but it helps us to understand why we could answer his first question. In people with Parkinson's disease or pure autonomic failure, ammonia means that the perfusion. This is measure of the cardiac sympathetic nerve. In pure autonomic failure and Parkinson's disease, there's no nerve. We have it with MIBG. With MIBG, it's not as nice as these pictures, but it's clear. This is a healthy volunteer or someone without Parkinson's disease or autonomic failure. And this is a typical patient. No heart, no uptake of MIBG. It gets me back to two other patients I want to introduce you briefly. One is a 60-year-old female. At 2013, she complained of orthostatic hypotension, anosmia, no issues with REM behavior disorder. At 2016, an MIBG scan showed no cardiac uptake. She was tested, she was examined at the movement clinic here at Tel HaShomer, and they said no Parkinson's disease, no signs of Parkinson's disease. But a year after, there was no doubt she's suffering from Parkinson's disease, and she was started on Sinemet. Or another 68-year-old male from 2018, he complained of orthostatic hypotension, no smell, erectile dysfunction, REM behavior disorder. He also did his round and looked for a cause with the antibody panel, which was negative. On evaluation, there was no doubt he's suffering from neurogenic autonomic failure, neurogenic orthostatic hypotension, and MIBG confirmed that there is no sympathetic nerve to his heart. Again, no motor symptoms. On the end of last year, I sent him to F-DOPA scan that showed reduction in F-DOPA uptake in the putamen bilaterally, not symmetrically, and a little bit on the caudate. And then I sent him to the movement clinic, and they said, well, subtle, early, mild Parkinson's disease already exists. And again, his complaint brought him to autonomic service and not to the movement disorder. So this patient, for a few years, suffered from autonomic failure and then developed Parkinson's disease. The question is, can we predict in patients with orthostatic hypotension, anosmia, etc., who will eventually progress to Parkinson's disease? And this is the question this patient, this 46-year-old man, asked, am I going to develop too MSA, LBD, Parkinson's disease? Tell me, what will happen with me? So I want to share with you these two publications that we have published about 2 or 3 years ago. Can we make a pre-motor diagnosis of Parkinson's disease? Of course, Parkinson's disease is the diagnosis based on motor dysfunction, but if we can look at patients with pre-motor symptoms, can we tell among them who will develop Parkinson's disease, like these two patients that I've just presented? So I want to share with you the PD risk project. Patients were screened, and if they had orthostatic hypotension, REM behavior disorder, anosmia, or family history of Parkinson's disease, 3 of these 4, they came for a comprehensive autonomic evaluation. They had 18-month interval follow-up, and the endpoint was confirmed diagnosis of PD. The study had 2 phases. It's going through 7.5 years. In about a year, we're going to end this project. The first phase is being able to predict a positive biomarker for those who will develop within 3 years Parkinson's disease. The phase 2 is to wait enough and make sure that we have an ability to say who will not develop Parkinson's disease. So we have results of the first phase. And among the patients that were tested, 15% eventually within 3 years were diagnosed with Parkinson's disease. All of them have decreased cardiac sympathetic innervation. Whereas those who didn't have PD within 3 years, most of them, almost 90%, had normal cardiac sympathetic innervation. So, with fluorodopamine, we can do all sorts of statistics and tell you that at a certain level of uptake, you can tell that within 100% sensitivity and 87% specificity, who will develop Parkinson's disease. And by looking at the heart, among these patients, we were able to predict, in retrospect, formulate, to be more precise, formulate who are going to develop Parkinson's disease. By looking at CSF, you can also have signs of central dopamine depletion with, again, ability to predict who will develop Parkinson's disease. Now back to our patient and his first question. In real life, there's no place where you can use fluorodopamine-derived radioactivity. That's why I have to collaborate with the NIH, because they have this facility. But what we have, as I showed you before, is MIBG. A question that I don't have the answer to. MIBG was done. It showed clear denervation, but is it as predictive as F18 fluorodopamine? I assume it is almost as good as, but I don't have data to support this. But should I send him for skin biopsy? Should I send him like the patient I've shown you to F-DOPA scan, DAT scan? How sensitive they are for early or pre-motor diagnosis? These are important questions. I asked for this test to be done on this patient. Skin biopsy is interesting. Again, this is one of the things that is not widely available so far, but alpha-synuclein deposition within sympathetic noradrenergic neurons in the skin is associated with myocardial noradrenergic deficiency. So I can tell this patient whether or not he is under this synucleopathy, autonomic synucleopathy, by looking at the skin. And these are structures of the skin, whether the sweat glands, erectile pili, or blood vessels. All are structures in the skin that are heavily innervated with sympathetic nerves. And if we look at the neuropathology, neuroimaging, they correlate the cardiac denervation in these patients, which I know they have Lewy body disease, but what's interesting is the correlation between the alpha-synuclein deposition in blood vessels, erectile pili, or sweat gland, and together with cardiac denervation. Lewy body disease, they have cardiac denervation. Non-Lewy or healthy volunteers, it's no doubt. And this is how it looks like. Within the same nerve, within the nerve, you have deposition of alpha-synuclein and of course, TH, immunoreactivity. So within the nerve, you have reduction of TH and alpha-synuclein. But I don't have this test available for clinical use. This is something I would like, and Nir and I discussed this many times. The information that we can get from the skin is amazing, but it's not something that is still in wide clinical use. So back to our patient, I can tell him it's not MSA, because MSA, they do, as I showed you with the fluorodopamine, and it's true with the MIBG, in most cases, not all cases, in most cases, they do have cardiac peripheral innervation is intact. There's good chances that he will develop Parkinson's disease, And now I'm moving on to his next question. Why is it happening? And it's important why for future treatment. Now, in Lewy body diseases, the three syndromes, we have drastic depletion of norepinephrine content in the myocardium. Norepinephrine, dopamine, epinephrine, DOPAC, and DHPG, which are the metabolites of norepinephrine and dopamine, the other way around, and drastic reduction in catecholamine in the heart. But there's something interesting. If we look at how much nerves are left and look at how much norepinephrine is left, there is more depletion of norepinephrine that can be explained by denervation alone. It's also true for the dopamine in the brain. There is more dopamine depletion than the amount of dopaminergic nerves depletion in the brain. So there's something here, you see, you expect if there is a reduction in the amount of nerves, you expect this amount of norepinephrine, but you get much less. So it says something about these neurons. So of course, we want to look for dysfunctional neurons because you can't treat dead neurons, but you can at least think of treating dysfunctional but alive. They are salvageable. And as I showed you here, not all of them are dead. The number of norepinephrine dopamine depletion reflects dysfunctional neurons that are still alive. Let's go back to physiology courses and look at the metabolism of catecholamines. And of course, tyrosine hydroxylase turns tyrosine to DOPA, which turns into dopamine, which immediately gets into the vesicles, where it can turn into norepinephrine. There is leak or exocytosis, depending if there is neuronal excitation or not. And the leak, of course, is either going back to the vesicles with vesicular monoamine transporter, which is very, very efficient transporter, But the dopamine that doesn't get into the vesicles, and it gets into the vesicle for two purposes: for high concentration in order to evoke a sympathetic response or a neuronal response, and because it's toxic, it's acid. You don't want to have it in the cytoplasm. And the norepinephrine and dopamine in the cytoplasm, which is far less than 1% of dopamine content and norepinephrine content, immediately turns into the intermediate aldehyde and DOPAC and DHPG, which are inert and can get outside. Now, the fact that you have less dopamine than expected and less norepinephrine than expected, you suspect there is something wrong with the ability of the vesicle to store and maintain dopamine. And we were able to show that in a paper in about 11 years ago at the JCI. If you inject a fluorinated dopamine and you look at the fate, how much of it goes to the vesicle, and you can look at it by means of PET scanning, and how much turns into DOPAC, and you can measure it in veins. You measure the F-dopamine in the artery and then in the vein. So you can have an idea how much goes to the vesicle, how much is stored in the vesicle, and how much goes to the cell. So if there is a vesicular storage defect, of course, we will have more F18 DOPAC for a given fluorodopamine intake. So it sounds complex, but if you read the paper and then you have time, you see it's very accurate. The results showed that Lewy body in synucleinopathies, the Parkinson and PAF, they have a vesicular storage defect. Whereas in healthy volunteers and MSA, where they don't have peripheral peripheral denervation, it's intact. So one explanation of the what is dysfunction, what are the dysfunction in these remnant neurons, dysfunctional neurons, is vesicular storage defect. Another way to look at that is the F18 loss. So if you have denervation and you inject F18 dopamine, so you have less. You wait until all is getting into the cells. And if you don't have enough cells, you have less, of course, uptake. However, if it's not stored in the vesicle, the rate of reduction of F18 is faster than expected. So that means that you'd have not only denervation, but also vesicular sequestration defect. This is a major dysfunction in this residual noradrenergic or dopaminergic neurons. And by the way, it is in correlation with the alpha-synuclein deposition in the skin. If we go back to the study that I've mentioned before, vesicular storage index and alpha-synuclein and TH colocalization goes together, whether it's a defect in patients with PAF or PD, or normal in healthy volunteers or MSA. Another way to ascertain what I've just said is to compare two modes of cardiac imaging. One is fluorodopamine that I've just mentioned, and the other one, metroreboxetine. Metroreboxetine is a sign of the amount of norepinephrine transporter. And if you have a cell, you have norepinephrine transporter. So if you have less fluorodopamine-derived radioactivity to a given norepinephrine content, it means that you have a vesicular storage defect for a given amount of residual nerves. And it says, I'll show you in pictures. That's nice. This is control. You have nice fluorodopamine. However, fluorodopamine-derived radioactivity is very low, where metroreboxetine is not that low. It means that, and the perfusion is fine. So it's not a myocardial scar we are looking at. So it's another way to show that in these residual nerves, they exist, but they are dysfunctional. Again, you can show this pattern even if you don't have, as I showed you before, this means the amount of denervation. And these patients that were tested here don't have denervation yet, but already they have the dysfunction. So early or even pre-Parkinson's disease, you can show that there is a defect, vesicular storage defect, before they even have the disease, before they even have the denervation, before the cells are dead. Again, in the PD risk, it's unpublished yet, but we have 6 years, not the 7.5 years. You can say that those with the defect and denervation are likely to develop, this is likely to stay without Parkinson's disease, and obviously they are more likely to develop the disease within 6 years. Now, is it the only defect in these cells? And the short answer is no. Now, if we look at the scheme of catecholamines, metabolism, fate, and all the biochemistry, obviously it's complex. If this goes down, this goes up, you can't look at one process and have an idea of what's going on. I mean, what I've shown you so far is focusing on the vesicular storage defect. But a system biology approach can tell you in a complex system that you have interrelation. One defect affects other metabolites and catechols, and you can look at one process and product, substrate, and have an idea what the problem with the enzyme, because they're all affected in a system that interrelate with each other. So you need mathematics, and we collaborated with a mathematician from University of North Carolina. And we asked the question, if you look at the system as a whole, and you provide them with the data, and I'm not going to go through these lines, but you have spillover of the metabolites, the rate of production, the rate of the content, the equilibrium of the different reaction rates. And you ask the mathematicians, can you put it in a model that will tell you simultaneously what and to what extent what is wrong in this system as a whole, not one process, at the system as a whole. And he put the numbers on all the different reactions. And to make it simple, this is what he found. There are multiple lesions in Lewy body diseases, in the catecholamine metabolism and synthesis and release. And it's not just one. Some of them, I can tell you, we were able to show in brain tissue of patients with Parkinson's disease, who died, obviously. And for example, ALDH is indeed decreased. And dopal is indeed increased. Now, I'm going to focus on dopal. This is the catechol-aldehyde metabolites that quickly turns into dopac. And if I said that dopamine is toxic, dopal is far more toxic than dopamine if it's in the cytoplasm. So it immediately has to turn into dopac. Dopegal is the equivalent to norepinephrine, but much more difficult to measure in biological tissue or fluids. So indeed, there is a buildup of dopal in patients with Parkinson's disease. So what? So dopal, as I said, is very toxic. It affects vesicular monoamine transporter. It has strong interaction with alpha-synuclein. It's a very aggressive oxidant. And we don't want to have dopal in the system. The cells that build up dopal eventually will kill themselves. So it's autotoxic. With alpha-synuclein, as I said, it's the title of my talk is Autonomic Synucleinopathies. There's no doubt that dopal enhances alpha-synuclein aggregation, oligomerization. And as to the question whether dopamine, and you know that there is some people who interesting statement whether dopamine itself is toxic, and when we compare the toxicity in terms of alpha-synuclein oligomerization and quinonization, meaning that protein malfunction, cellular protein malfunction, dopal is by far, this is the middle line is dopal, this is control, and this is dopamine. Dopal is by far more toxic in terms of oxidative stress, oligomerization of alpha-synuclein, and cell toxicity. And particularly if copper is available. And that's something I want you to have in mind towards the end of my presentation and the discussion. What can we do with this information? So to summarize, the question this patient asked me, why is it happening? It's very small. This is taken from a few months ago. We put together a Lancet Neurology review that highlights some of the stuff that I'm just presenting. So there you can do a close-up and see. So this is initiation. In the initiation, we have a VMAT, a vesicular monoamine transporter defect, ALDH defect, and therefore the ability to store dopamine or norepinephrine in the vesicle is reduced. So we have increased dopal and dopegal that affect alpha-synuclein oligomerization and other cellular protein malfunction, quinonization, and eventually cell death. And if we look over time, something that will represent this process, this is a fluorodopamine-derived radioactivity over a few years, 5.6 years, with initiation, progression, and then the degeneration. So why do I focus on the heart? Because the heart, the cardiac sympathetic nerves are particularly susceptible. Maybe it's because they're very active, 100,000 beats per day. Maybe because the oxygen demand is one of the high in the body, or other reasons that I'm not aware of. Maybe you can give us some ideas, but they are more susceptible. And I can show you that if you look at the alpha-synuclein and TH colocalization and compare different organs, submandibular gland, which of course also are innervated sympathetically, myocardium, and scalp with all its hair follicles, etc. And these are controlled, and these are the reds are Parkinson's patients. And of course, you have more alpha-synuclein. You have more in the heart of tyrosine hydroxylase, and much less norepinephrine. And if you remember, we said that there is a defect. And it's important because maybe we can now think of how to salvage that. So far we can say that separately assess sympathetic denervation and vesicular storage defects, and I hope I have convinced you that there's a mismatch, and in the residual nerve there is some vesicular storage defect, and not only, there are other functional abnormalities in the residual sympathetic nerve, and I don't know if cardioselective is the right term, but definitely the heart is more susceptible, and it can occur very early in the disease process or even in a premotor. So back to our patient. Now that you know all this, can we prevent it from happening? That's the big question. And I can tell you, I was standing in front of him, and that's what bothers him most. I think I know what's going to happen, and I want to think with you to have an idea what can we do in order to stop it. Like these two patients that I've shown you that I wasn't able to stop it. So our overall goal is to delay the onset or at least slow the progression of autonomic nucleopathies. Now, what first comes in mind, dopa lowering. Let's give MAO inhibition, less dopa. Now, the failure of MAO inhibition, and this is the scheme why it makes sense. The failure of MAO inhibition, actually it's later on. So first of all, I want to have a model that replicates the multiple functions, dysfunctional elements that are known in human, an in vivo model. And we tried the rat-Rotenone model, and we were able to show that the striatum of this rat, if we give Rotenone or vehicle, we have increased dopal and decreased ALDH, vesicular monoamine transporter function, and LAD. And if we just try and give MAO inhibition and to see whether if we reduce dopal in these rats, it did help the locomotor abnormality that we were able to produce with Rotenone. But we all know that MAO inhibition doesn't slow the progression. And the question is why? Why? Because, you know, if you mention this option to many of my colleagues, it's like asking a post-traumatic someone to go into the battlefield. No, it's not going to help. They're right. It failed. But let's see why it failed. And I want to suggest two options why it failed and why we why we should not completely abandon this approach. One is this explanation. When you give MAO inhibition, selegiline, of course, dopamine is increased, but in this patient, the VMAT is abnormal. So the increased dopamine doesn't go to the vesicle. So it turns into cysteine dopamine in the cytoplasm, which is oxidant, which can again damage the cell for itself. So let's try and give N-acetylcysteine. So what we show in PC12 cells, far from being relevant to humans, but in PC12 cells, the more selegiline you give, the less dopamine you have, so it does what it's expected to do. However, cysteine dopamine, which is the oxidative product of cytoplasmic dopamine, is increased. And if we give increasing doses of N-acetylcysteine, we can prevent this increment of cysteine dopamine. So this is one explanation. It may not, especially in patients with Parkinson's disease, it may not be enough to give MAO inhibition. It needs something, an adjuvant treatment. It's hypothetical. The other thing I want to propose is a matter of timing. Since it's a progressive disease, we went back to this mathematician and asked him, and we gave him all sorts of data that can look at norepinephrine depletion over the course of time in this patient. And it's not linear. It has a triphasic mode, which, by the way, since I have to finish soon, I won't get into it. It's going, in a month or two, it's going to be published in the Journal of American Heart Association, so we'll be able to look at the details. And we tested this in treatment, in genetic models, in all sorts of situations to see whether this biphasic mode is valid. So what we see, there's a homeostasis and dyshomeostasis, and then degeneration. Why is it important? Because when we tested this model and asked the model, if you give selegiline at this point or at this point, what is the prediction? And the model says, if you give the selegiline here, you can get increase in norepinephrine store and of course also in dopamine stores, but it doesn't change the slope. So after a short period of time, you'll get to where you began with depleted norepinephrine and dopamine. However, if you give it in the beginning of this homeostasis, you may slow the progression of asymptomatic disease for a longer duration of time until the end. So again, hypothetical. So I gave you two options to think of, to proposing. I have no proof of that maybe MAO inhibition alone is not enough, and maybe the timing. Now, can we apply biomarkers that will tell us where we are in this patient in this course? That's a very important question, which I don't have the answer yet. So treatment, potential targets, and it's more I have a dream, especially to this patient that I saw last week. Dopa lowering, as I said, and maybe with an adjuvant therapy, maybe mitigating dopal toxicity, maybe targeting alpha-synuclein aggregation. And last time we met at Zichron, there were all sorts of presentation of ideas, what is enhancing alpha-synuclein aggregation or oligomerization. Can we direct our treatment to alpha-synuclein dopamine interaction. And there is one study in Journal of Biochemistry, I think, that suggested that dopamine is the link, is the glue between filaments of alpha-synuclein. And if I said copper is a coenzyme that is important, maybe copper lowering, again, be liberal with your thoughts. Sa from the movement clinic here found 2 papers about VMAT enhancing strategies. But what I believe, it's not one thing that we will do and all the card will collapse. In oncology, in hypertension, where I deal with mostly, in many areas of medicine, we were more successful when we combined treatment. So maybe combined strategies will help us to help this patient. So to summary, what are the answers to our patient? One, we can predict the course of the progression of his neurodegenerative process, but we need to improve and refine these biomarkers, skin biopsy, MIBG, FDA, maybe we can use it. I know that in places for oncologists having cyclotron in many medical centers, maybe using FDA will be available. Sorry. We know he has salvageable catecholaminergic neuron, and I hope I've convinced you that there are dysfunctional, but still residual neurons. And again, in many areas of biology, all you need is 15%, 20% to maintain some good function of a system. So if you can salvage these neurons, I hope that it will translate to a much better clinical outcome. We have some theories, and I hope to hear more theories from you, so we can again maybe combine these theories to a more comprehensive paradigm. But we must make some effort to complete the missing pieces in this puzzle. And we have some ideas, I would say dreams, I would say wishful thinking on neuroprotective strategies, ideally mechanism directed, and hopefully the issue of timing and being able to personalize the timing will help us to get there. So are we approaching an era where we can modify the neurodegenerative process in Parkinson's disease? I truly, truly hope so. And I want to thank first of you for your attention, and for the colleagues who helped me and I helped them to come up with these ideas at Tel HaShomer and Tel Aviv University and at the NIH. And this presentation is open for discussion.
Thank you, Jonathan, for this very elegant, beautiful overview, and especially how much you have been contributing to this field over the past 2 decades. It's really impressive. Maybe I will start with a question. Do you think the autonomic nervous system, which is the biggest one, much larger than the brain, for example, has some selective vulnerability? So some neurons are more vulnerable than the others, and how can we start differentiate?
I do think there are, especially in synucleinopathy, they are more vulnerable.
Within the autonomic nervous system, not in the general one system, but different neurons, skin versus cardiac versus GI.
Definitely. I took out this slide in view of time that there is differential susceptibilities. Why? One very trivial explanation is systems that have a higher oxygen demand are more susceptible to oxidative stress, and maybe it starts a vicious cycle that eventually turns. So the answer is yes. Your question is about differential susceptibilities. Yes, the heart is very susceptible, but you have differential susceptibilities. Area which is by and large is not known as much as sympathetic noradrenergic nerve, of course, is the gut, the enteric autonomic system in the gut. But the only the thing that is unique in cardiovascular system is its continuous ongoing activity, and maybe that's what makes them susceptible. Any other ideas?
Jonathan, thank you very much. To continue on this same topic, so eventually it is not only the catecholaminergic cells that are affected. It goes on beyond to the cell where dopal would not be involved. So
dopal is definitely involved in the cells, and in different models you could see that intracytoplasmic dopal is toxic. In PC12, it's very easy to show because you can count the number of cells that are dead, and it's a dose response correlation that increasing dopal not only affect different proteins, but it affects cell viability directly. So yes, other systems that are affected in the brain, cholinergic, serotonergic, how can I combine them in this paradigm? I don't know yet. Don't know. I don't have tools to study these systems. Bioaminergic, that's the only what some of them have in common. But yes, dopal is toxic in the brain and contributes to the progression. But I'm focusing here on the phase, which I think is gets years, even when the symptoms begin, that there are still salvageable neurons.
Uri?
Thanks for sharing with us this knowledge. Do you know, and follow up for the two questions before, do you know if the dopal hypothesis was checked in induced polypotent stem cells?
I'm not familiar with this. I don't know. I don't know. Avi, maybe have some idea? Avi Ashkenazi? No.
From what I know, I don't think it was investigated thoroughly. I think dopamine, yes, but not the metabolites.
Okay, let's see whether, if soon we have some dopaminergic neurons, maybe from patients, we might be able to test it. So
amazing.
Avi, you wanted to ask?
I want to ask several questions. So if I will continue with the dopal, so dopal in the blood, can one measure it, and whether you are familiar with the concentration that you say this is not normal, this is normal?
Dopal in the blood is cannot be measured properly. You can measure it in tissue. It's the amount is very small. I'm hoping in the future that advanced biochemical analytics, especially with LCMS, you will be able to measure small amounts of dopal. So we'll have, like in oncology, blood biopsy, what they call serologic biopsy. No, there's a nice name for that you can have biomarkers in the blood for even very genetic malfunction. So maybe in the future, but you can measure it in LP. And you can measure it in if you have enough amount of tissue. That's why you needed advanced disease and postmortem.
And also another. So I have many questions, but I will not do it today. But for the doctors in the audience, so what is your view? For example, I turned 40 not long ago. Okay, and then I got from Kupat Cholim like an alarm that I need to come and test my blood pressure because this is a high risk for cardiovascular diseases. So what about, having this in the age of 50, these alarms for people to come and fill up questionnaires about their smell, about their do some blood tests of orthostatic hypotension, or some that can be predictive, or maybe then refer to a neurologist? How it is developed, this connection between the neurologist and the family doctors in that area with the autonomic dysfunction? How you see it?
By the way, it was done in Hawaii. I think it was older than 50, but the Hawaii study, they saw that anosmia, they gave smell study for elderlies. I think it was more than 50. I don't remember the exact details. And 20% of those who reported anosmia developed Parkinson's disease. So it's a very good biomarker. I think you have very good cohorts on that.
I will share with you that the Austin Center has been establishing over the past almost 3 years a website where healthy people from Israel are registering and actually reporting about prodromal signs, and we get their likelihood ratio to develop Parkinson, exactly in the same line that Avi has suggested, to detect those who are at risk. The next phase is sending them a smell test home, and we hope within a year we will start having some more solid data. At the moment, we have close to 1,500 people who have registered already. So it's growing up, and actually, if you could promote this website, it's called APPD, Israel Prodromal Parkinson Initiative. Exactly to follow Avi's idea.
I can't wait to your cohort. It's an extensive, large, and very good cohort, which will give many answers as well as to Avi.
Roy?
Yeah, just to say that I think that the IPPI project is ethically better than just telling people at 50, now you're at risk for this and let's test it, because the people that choose to go to the website and fill out the forms are already, they know what they're doing. I can tell you from just a couple of experiences I had the past week from a friend who was a neurologist that did genetic testing for prenatal testing, got the results, she's a GBA carrier, and even though she already knew that, she freaked out because it said that her risk for Parkinson's is increased, even though she knows that. So people need to want to be in an at-risk population when there's no interventions that we can offer them right now. So the website like IPPI is great because you don't force people to join. If they join it, then we can do all these analyses. But I had another experience again this week of someone who told me about her RBD. And you wonder whether I should tell her that she's at risk for Parkinson's. I chose not to.
But I would like to ask, especially those who are involved with research about mechanism. And again, I'm troubled because I saw this young man. It really hit me more than others for some reason, because he was, in his beginning of his life. Any again, wild ideas 5 years from now, how we can, given in the right time, again, what strategy would translate to disease-modifying neuroprotective strategy? The dopamine is like giving him a fish, so we'll have dinner. But I want to teach these cells how to live. Any wild ideas?
You can tell what is already being done. So that one of the thoughts would be in the people with genetic causes of PD to inhibit the gene like LRRK2 or activate the gene in GBA, even as a before the disease starts. The clinical trials now focus on people with Parkinson's, but the idea is that if they work, the next stage would be people without Parkinson's.
So should I send him to genetic testing? That's a good idea.
Sure. I mean, again, if he wants to know.
I think for the sake of time, we are over 3 p.m. and so we have to finish. I think this is a discussion by itself for a whole lecture that we will definitely present, bring up.
And the brainstorming in June.
How to modify, how to detect the risk and how to modify it in pre-symptomatic subjects. Definitely this is what we are all working for. So once again, thank you very much for
Nir,
Karen, sure.
Nir, if would you, I just want, before everybody hangs up, so let me say something and then you'll say the closing words if we may.
Sure.
Okay, so I'm just going to share my screen very quickly with everyone. Can you see what you see on the slide now? We're having a conference on April 11th at Small Rs from 9 to 3. Fabulous organization by Rinat and her team, Sharon Hassin and others. This is really dedicated for patients and their families. But if you're interested in coming and learning more, I'm sure there's going to be a lot of valuable information for us as researchers and clinicians who care for these patients. And if you do have people to invite, please, you can get that information from us, from Rinat, and send it out. We'd really love to see as many people as possible to take advantage of a really outstanding schedule that we've put together. Thanks. And now, Nir, it's yours.
Yes, thank you, Karen, for bringing it up. And it's for patients, for families, for researchers, and for students. So definitely encourage your students to come. So Jonathan, thank you again for sharing with us all this exciting information. I think this is another area that is fastly growing of how to understand the autonomic nervous system and hopefully to intervene early enough to prevent Parkinson. So it was really stimulating. Thanks and Chag Sameach, Likrat Pesach.
Chag Sameach, everyone. We'll see you April 11th.
Chag Sameach, see you 11th.